And so with that, I would like to present Dr. Joseph Mberikunashe. Did I pronounce it correctly?
That's correct.
Okay, from Zimbabwe, who will speak to us about Zimbabwe's activities. That one is to move forward, yeah.
A very good afternoon, colleagues, ladies and gentlemen. I'm going to give a country perspective in as far as the collection of surveillance data is concerned. Zimbabwe is a country that's in Southern Africa, and together with 7 other Southern African neighboring countries, we formed what is called the Malaria Elimination 8 with an ambitious goal of moving fast towards elimination, and we needed to work together as the neighboring countries. I am going to give an update on where we are as we try to improve on data collection. That's the outline of my presentation. I will talk a little bit about the background, an overview of our backbone for health information management system, the DHIS2, some expected benefits of this, the performance that we are seeing so far, and some indicators that we are looking at. And of course, there will be a sharing of the challenges that we faced. We are a country with about 3.1 million people. Of late, we are recording malaria cases that are less than 500,000, and we're still concerned about some malaria deaths. Our major parasite is the falciparum, and the vectors are those 2 notorious Anopheles arabiensis and phenistus. Over the past decade, we've seen a steady decline of our malaria cases in the country, or malaria incidents. We deploy a wide range of the WHO recommended interventions. For looking at IRS, we have had a long history of IRS since 1949 to date. We also have bed nets, which have not put the, but we switched to the ACTs around 2007 and rolling out the RDTs by 2009. And soon after, we also then made a decision that we should start to explore pre-elimination in one of our 10 provinces. We have a strategic plan that's a bit ambitious again, where nationally we would want to see our incidents coming to 10 per thousand by 2017. And we have an objective number 4, which also talks about elimination or pre-elimination. The province I was talking about is here, and it borders with Botswana and on the south and west parts, as well as South Africa in the south. It's got 7 districts, and they've been consistently recording malaria incidents of less than 1 per thousand. And we felt that just sitting back and not doing anything in terms of pre-elimination is like waiting for the problem to come back. We have a very robust and widespread health information management system that rides on the DHIS2. It has one component that's called the Rapid Disease Notification System, which is SMS based. It's meant to pick outbreaks or epidemics when they happen. And then we also have the standard T-series system, which collects data on a monthly basis that's validated at all levels. Within our elimination context, we realize that we want to collect data for action. We would want to mop out all the parasite carriers in an area. So we practice a 1-3-7 a day algorithm. Day one being as soon as we see the patient that comes to the facility, they get a diagnosis, parasitological confirmation done by RDT. A slide is collected for microscopy, and that is sent for reading. The information is passed on to the environmental health technician. These cadres they work with the communities. They follow up infectious diseases contacts within the community. And within 3 days, they should have followed up the case to test the contacts and to confirm on some of the aspects that would have been collected by the health worker that first saw the patient. And within 7 days, they also supposed to have done an environmental assessment around the case. So that's the algorithm that we work with. When we started this in 2012, we based all this work on paper as data collection tools, and we had 13 forms that are to be completed within this period. And you can imagine the amount of work that entails. The forms are supposed to be sent upwards to the district level, from the facility to the district level, from the district to the province to the national office. So we realized that this was quite a hard ask of our cadres. And of course, we are also probably fast running out of space to store these papers. So we looked at what options we had, and we took advantage of the expanding telecommunication developments in the country, and realized that we needed to ride on this development. So we introduced this tool, the tracker, where the data, all the 13 forms are now put onto a tablet, the Android-based tablets, and the cadres then upload or capture the data using this, and they transmit to a central server, where all the other officers with the rights to the system can actually view, and it's almost it's now real time. So going back again, this is 2012. We had 13 forms that were being filled, and then in 2014 we started by using personal digital assistant tools in the 7 districts, and we continued to look outside for better tools, and we then moved on to the tablets. And within the DHIS2, a module was created that we call the DHIS2 tracker, specifically for pre-elimination areas. That's one of our environmental health officers or technicians getting ready to take off and follow up a case as soon as they get the information from the front desk. So basically, because the system is built on an existing DHIS2 platform, which is covering all our public health facilities in the country and all the admitting health institutions, with, of course, the hope that it will start to capture even the private practitioners' rooms. We believe that it enables us to expand faster in the future because it's writing on an existing system. It's got a remote software updates through the F-Droid function. And this means that should there be any upgrades that happen, it can be done centrally, and all our users get the same update, as opposed to each individual deciding to upgrade, and then in the end some distortions could happen to the data that is collected. It also has robust permission system. It's got that where we have different access allocations to the various levels that I talked about. We also think that it's quite sustainable, because the whole health information management system is the backbone to this. Just a snapshot of what has happened. One of the aspects is to make sure that the cases are followed up as soon as possible. So our case investigation rate when we were using the papers was very low, understandably so. Maybe some papers were getting lost between the front office and the environmental health officer. And when we moved on to the PDAs, there was some improvement. And now with the tablets that are there, we seem to be seeing significant improvement. Of course, we have had some teething challenges with this system. We got a bug which has just been fixed sometime last week. It was also causing a little bit of delays and so on. We feel that it's a bit too early to judge this because we just started to roll it out. But our hopes are that it will improve the timeliness and, of course, the quality of the data that will come through. These are some of the indicators that the system helps us to see. The cases that are seen, whether they are local or they are imported. In our case, because we are doing region by region, within a particular province, if a case is seen, we call that intra-ported if it's not right where it is. But it's just for use at the local level. Our data is also aggregated by age and sex. We are able to determine how many contacts were screened and how many of those were positive. We also give low dose primaquine for the positive ones, and we're able to capture that. These are some of the outputs of the system. We are able to then map the cases just by getting into the system and seeing how many cases have been notified or reported in the system. You can actually come up with a map and say, these are the cases that were seen where, and they also by class of the cases, whether imported or local. This is again another aspect of it. We can also be able to relate the clustering of the cases to interventions that have been deployed or have not been deployed at that area, and that's be able to make appropriate decisions and action points. Yeah, we still have some work to be done to encourage this culture of using data by all levels. We believe that it's an ongoing process that needs to be strengthened. There's still some pockets in the country where the coverage for cell phone is still not optimal, and we still experience delays in some of those areas in terms of notification. And there are other areas where the case burden it's become so low that, for example, I can give an example of one district where they see 2 cases per year. And so when you see one case, you've been trained, and then you don't see a case, and the next time you see that case, you've probably forgotten what to do. So we believe that we may need to come up with very comprehensive job aids and some mechanisms to make sure that the practice is not lost. There will also be issues to do with logistical support that has to be there as and when it's needed. So we conduct support and supervisory visits in these areas to try and continue to motivate the cadres and make sure that the system is working as expected. And we're also creating a dashboard that will be used by the various management levels, so that they are literally as if they're on the ground and be able to give direction when needed. We are developing some guidelines to assist with use of data for all the levels. And the training is continuous and ongoing. I would like to stop here and acknowledge all the partners that have supported us and that continue to help us to move forward. I thank you for your attention.